Hello and welcome to this two-part lecture on bringing neuropalliative care to under-resourced communities. I am Roop Gursahani and I will speak first, followed by Dr. Suresh Kumar. Let me begin by thanking IMPCS, especially Benzi, for suggesting this topic and inviting me to speak. I have no disclosures relevant to this presentation. Now, I am a neurologist in practice in a private hospital in Mumbai, and my only connection with rural India, other than occasional referrals, was through my volunteering work with the Lifeline Express. Till the pandemic began, this meant about 10 longish weekends a year on this hospital train, and one of these weekends was dedicated to an epilepsy clinic. Please note the crush outside, waiting to enter, a well organized waiting room inside, but pictures of patients and my own realization that epilepsy could be disabling and disfiguring where there is no primary care. Uttar Pradesh is a state with terrible socio-economic indicators. These are not pictures that I would expect to ever see in my Mumbai practice. So I guess I was not in a minority to believe that rural India's health problems had to do with deprivation and infectious diseases. And I was surprised to see this paper from my friend Yogesh Kalkonde, who works with a not-for-profit in a rural part of my own home state of Maharashtra. Using verbal autopsies, his group was able to show that stroke was the leading cause of death in this largely indigenous tribal population. And that led me to Omron's theory of epidemiologic transitions and demographic and population change. Mm, This pans out differently in various parts of the world depending on economic and political development. And these authors who wrote this almost about, I think, 30 years after the original Omran story actually added a fifth category of health regression amidst social upheaval. But the important thing for me to point out is that even rural India has already passed the age of pestilence and famine, past the age of receding pandemics, and is now in the age of degenerative and man-made diseases. Um, so the big picture now is that across the world, neurologic illnesses led by stroke and dementia are the leading cause of disability and the second leading cause of death. This became obvious after the 1990s as international public policy pivoted away from maternal and child health and infectious diseases. And these numbers are rising. And unlike stroke, where you expect, at least in theory, control of hypertension to reduce the numbers, dementia is set for a 250% increase by 2050. And low and middle income countries will bear 80% of this burden. So, how are we in the incipient neuropalliative care community preparing for this? I think it's good to take a look at the state of palliative care in various countries, which obviously differs widely. So, in 2010 and then in 2015, the Economist of London, together with the Lien Foundation of Singapore, published these superb reports on the state of end of life care and then of palliative care in in those years. Sorry, and they ranked various countries on multiple parameters. In the first, which had 40 countries, India was at the bottom, and it was a little above that in the second. But most developed countries, it's important to remember, are in the top 20, 10 to 20. The United Kingdom actually topped both lists, and in substantial part, uh, I guess it was because Hurricane Sicily had already blown through it. Somebody actually called her that. As an aside, please do read her short bio on the Cicely Saunders Institute website. She was obviously a remarkable person. And also, as an aside, the 2020 Quality of Death and Dying Index survey is currently in progress. So, what does it take to get adequate palliative care for anybody? The first is preferably a comprehensive national action plan for palliative care. And then palliative care has to be integrated into universal healthcare through a national healthcare system or through insurance. Then you need an adequate supply of palliative care professionals from all streams, which means specialist training that is accredited by national bodies, standardized training for volunteers, including family caregivers, and all of this then makes interdisciplinary care possible. You need clear criteria for accessing palliative care so that there is adequate information on how to avail funding or service. You need obviously easy access to opioids and psychosocial support, and for opioids you need safeguards because this access is essentially meant for opioids. And together with this, you need public awareness of dying matters and palliative care. For instance, in Kerala, uh, which is probably the most successful palliative care service in India, it all began in the initial stages with a prominent media house taking it up as a cause. Uh, but then volunteerism, adequate counters for the usual taboos, all are needed because it's only after that the community really starts to get engaged. Then, end of life care at home has to be not just prioritized, but it has to be standardized and adequately supported by caregiver training so that it gets built into the system. Obviously, you do address ethnic and cultural nuances appropriately, but you do need to focus on individual autonomy. The last bit, advanced care planning, needs policy changes and a system and cannot happen without political and legal backing. And this then leads to the institutionalization of shared decision making. When it all comes together, an individual at the end of a life can and should expect to have all of this provided by public agencies without any financial burdens, palliative care at home, and hospice admission, if required, should be able to ensure an almost pain and symptom free death. Information as she wants and as she needs should be conveyed sensitively to her and her family with due regard to autonomy and her choices. And an actionable advanced medical directive allows for her values and wishes for end of life care to be discussed, recorded, and used when needed. If my patient is unable to communicate or unable to even comprehend, issues of ethics, law, and medicine would need to be addressed. And for this, you need a designated legal agency, and all of this needs to be done reasonably expeditiously. Mm, the United Kingdom Court of Protection system is the best in the world. And if anybody has not been exposed to it, I suggest you follow Professor Celia Kitzinger on Twitter to get updated. One of the reasons the UK heads the list is uh, all these services are delivered by public agencies for all UK citizens. So, how do you bring all of this to our patients? Now, obviously, there are different models. They're not exclusive. They probably flow into each other. As of now, I only have access to the consultative model in the private hospital that I work in because we have two palliative care physicians who work with us. Now, they see patients uh, based on case reference. This obviously has fairly limited reach, but setting it up only entailed recruiting them. That is it. If you want to have a fully integrated system, this is possible, I guess, with universal healthcare. It needs collaboration between providers from neurology and palliative care and strategies for involvement of specialist palliative care. Uh, you will realize that this is something that is a work in progress, and there are there is already literature from the UK on how this has worked out in Parkinsonism and dementia. The United States, of course, has this better sorted out uh, in patients who are eligible for hospice. And uh, before that, uh, even there, it is not very easily done. Probably another good way of serving patients is through disease specific multidisciplinary teams where palliative care is incorporated as part of the MDT. Now, MDTs are basically niche services and they do have huge research benefits. For motor neuron disease, for instance, survival and quality of life benefits have been shown. Quality of life benefits have been shown for Parkinson's disease. And one of the things is that these MDTs, because they can advocate, they can develop funding independence. The next is primary neuropalliative care. What do I mean by primary neuropalliative care? This is when a neurologist with motivation and training in palliative care becomes the primary palliative care provider. Obviously, calling in specialist palliative care when required along the course of the illness. And the last is community or communitarian services. When the palliative care is provided by primary care that is run through the universal healthcare system of that country, and it is supported, all the gaps are filled in by community volunteers. And this leads me to the term that has been used, compassionate communities in cities. Uh, Professor Alan Keller here from the UK is a leading proponent of this, and he has spoken about the public health approach to palliative care, where end of life care becomes everyone's responsibility. In the compassionate communities and cities approach, you need social awareness, public education programs, programs for training caregivers, and then you need to set up systems for home based palliative care with community volunteers. Service delivery organizations, whether from whether these are government funded or these are not for profits, do need to provide support and they need to chip in with the training programs, especially. Uh, Even social awareness and the media awareness needs centralized planning to some extent. You will um, probably hear some more about this from Dr. Suresh Kumar, but let me actually tell you that around the same time as the previous action was happening, um, a remarkable initiative was taken place in the Indian state of Kerala. Dr. Suresh Kumar was part of the team that began what has been termed neighborhood networks in palliative care in the 1990s. And today, this has grown to the point that palliative care is practically a mass movement all across this state. It also addresses the lack of social support from public agencies. So you will see that patients who, for instance, patients with spinal cord injuries, the organization of even rehabilitation is included here. Now, it's important to understand that this takes a historical and a social context. Uh, the paper that I read, which wrote about this, called this poisonous for social innovation. It's a rather nerdy term, but actually it makes sense. And I'm quite sure that this could not have happened uh, practically anywhere else in the world except Kerala. And when do neurology patients enter this? This quote at the bottom tells you when and how that happened. And this was a volunteer who said if a cancer patient receives care, why should a paraplegic patient not receive it? He also suffers. So the point is the community recognizes suffering, does not recognize disease or prognostic categories, and they drive coverage for neurological illnesses. Because when it is top down coverage, our patients generally do get short-lived. So one hot day in 2019, I shadowed my friend Dr. Anil Paleri. He's a palliative care physician and a colleague of Dr. Suresh Kumar in the same organization. We saw about 10 neurology patients under his care. He lined them up for me. And we were, traipsing around in the heat for almost about 5 or 6 hours, going from driving from one home to another, but then needing to talk also. But the image that I took away from that day was in this photo. We stopped for chai, a cup of tea, and I noticed this collection box on the cashier's counter. Anil told me that this service in this area was largely supported by micro donations that flowed into collection like boxes like this, placed all over the area. I cannot tell you how much that touched me. There's another insight from Kerala relevant to us, and this is from the first unit that was set up by Dr. Suresh Kumar's team at in a district called Mallapuram. Our patients, our neurology patients, are often voiceless with long and indeterminate prognosis. Unlike cancer, part of the reason they are grossly underrepresented in legacy palliative care. But when the criteria for inclusion are community identified needs, see how the numbers change. So when palliative care began as a community-based initiative in this state, in Mallapuram, 90% of the work was cancer. But as the community started to identify the patients who needed this service, well, my estimate is that 40 to 50% have neurology needs. Now, because neurologists are not involved, we really do not know the diagnostic categories in these lists. I'm sure Dr. Suresh Kumar will be speaking a little more about this. But this is a research project that is waiting to be done. So, what are the barriers to neuropalliative care? The first is from our side, neurologist side, sorry, a lack of exposure to palliative care during neurology training. From the palliative care professional side, it's a bit of diffidence about handling neurology patients. And neurology and palliative care have historically had very little interaction except through perhaps motor neuron disease. The next is resources. Now, when palliative care is provided by charity or not-profit agencies, the uncertain prognosis and the prolonged survival make budgeting difficult, especially when patient selection is top-down. As a palliative care colleague mentioned to me once, in cancer, I know that my budget for a patient, my commitment, and the patient will all expire together. That doesn't happen in neurology. Community attitudes to death and dying can also be a barrier to neuropalliative care. They with cancer, obviously, these are prognoses that are accepted, but not so for, say, for instance, for dementia. So these were some of the points that were also highlighted in the only paper I could find on this topic from Janice's group. They found another couple of pointers. This was for Parkinson's disease. One was that neurologists didn't like the idea of losing control over their patients. The other was their own belief in their omnicompetence. This I can understand to be unaware of available services. And from palliative care physicians, again, it was lack of domain knowledge. Um, Oncopalliative care has a kind of a visual model which does work to it, where disease management eventually dwindles and hands over to specialist palliative care, and specialist palliative care uh, can overlap with survivorship and rehabilitation, as also with bereavement. But you can see that this is a kind of a handover. This visual model, this visual representation just does not work for us. For us, what we need is a visualization of a roadmap model where we and our patients walk together over a lifetime. So, how do we make this happen? IMPCS is taking the lead in making sure that effective training in neuropalliative care is available for all physicians and others who need to take care of patients with long-term neurologic conditions. In addition to EPEC neurology, we plan to set up a 12-month modular course, and this will be, as I said, for all physicians and others who manage these patients. We'll be using pre-recorded didactic material, a flipped classroom model for live teaching, and we plan to start uh, in the middle of next year. Please watch out for further details on impcs.org. Now, in the pictures I showed you, I took you from Mumbai on the west coast of India to Ghazipur in eastern Uttar Pradesh to Gadchiroli, practically in the geographical center of India. And now I take you to Kerala, which is in the south on the west coast again. And this, of course, is from a tourism brochure of almost a decade ago. It is my privilege to now introduce to you Dr. Suresh Kumar, who will take you to this tropical paradise. He's one of the trailblazers in palliative care, not just in Kerala, but also all of India. He was responsible for much of the conceptualization of the neighborhood networks system, and his deep insights into community palliative care have been applied across India and our neighboring countries. Dr. Suresh Kumar.
Hello, I am Dr. Suresh Kumar, Director of a WHO Collaboration Center. We are based in Kerala. Kerala, as many of you know, is a small state in India, and we have been experimenting. The state of Kerala has been experimenting with community-based palliative care for quite some time, and I hope to share some of the results and some of the impressions from it. As you know, all the patients in need of palliative care, whether due to advanced cancer, whether due to an advanced neurological problem, whether due to old age, they all have some common issues. Some of the problems that they face are physical issues, then social problems, emotional issues, and spiritual problems. And all these together add to the suffering, and all these together make their life miserable in the last days of life. It's the same in India. India has altogether something like 718 districts, and a district with an average population of 3 million is estimated to have more than 12,000 people in need of palliative care at any point of time. And on an average, when you look at the different districts in India, on an average, less than 50 among these 12,000 receive appropriate care. This is the situation in India, whole of India, except Kerala. So, what's happening in Kerala? Kerala, with 1% of the national land area and 3% of the population, claims to have more than 70% coverage in palliative care as against the 2% of the national average. And when you look at the palliative care service in India, you can see that 84% of them, 1,600 out of the 1,900 services in India, are in Kerala. As Roop mentioned earlier, it all started with a community-based experiment called a neighborhood network in palliative care in one district called Mallapuram. And the district administration took an initiative bringing together the civil society represented by this network and the political system represented by the district panchayat and the government machinery through the health and social justice department. So this has been a coming together of different players in one district, and then after the pilot, this got expanded to other districts. Who all are being covered by the palliative care system in Kerala? When you look at patient data, patients registered with this community-based palliative care units, and we found that approximately 25% of them are people with advanced cancer. Approximately 15%, a fairly high percentage of them are people with spinal injuries, traumatic spinal injuries, paraplegia and quadriplegia. And then approximately another 15% are people with stroke, and then progressive neuromuscular conditions, differently abled people with severe physical and intellectual disability. They constitute around 5% of the total patient population. And another like systemic diseases, end stage renal disease, 5%, other end stage systemic diseases, 15%, and old age with multiple morbidities, approximately 20%. You can see that out of the total 15 plus 15 plus 5, 35% are people with neurological problems. And what are the services offered to this patient? This patient also get outpatient services and inpatient services, but basically these are services offered at home through the home care program. And when you look at the services, you can see that the trained volunteers visit them and they offer psychosocial support and emotional support. And then the follow-up visit by trained palliative care nurse, regular frequency, the frequency depends on the need, and they empower the family on basic care for the bedridden patient. They help them in the wound care, train the family members in wound care, catheter care and catheter change, nasogastric tube and care and change. And then special care like lymphedema and ostomy care is also available. And basic physiotherapy. There are physiotherapists attached to these home care units. They train volunteers and they train the family members and they supervise physiotherapy. They are also provided with mobility aids like wheelchair, walker, and etc. And the whole thing is supervised by a doctor in the primary healthcare center or the doctor in the non-governmental organization. And the doctor also visits when needed. And the medicines are given free of charge. These are the basic package of services that the patient get at home. There are social and vocational rehabilitation projects like the one shown here. The main beneficiaries are people with neurological problems. Main beneficiaries are people with spinal injury, people with stroke, and people with a lot of people with other chronic long-term conditions also could benefit from this. What makes Kerala different from other places is the key message. The key message in Kerala has been that palliative care is everybody's business. It's not for the doctor, nurse, or the hospital or the healthcare facility, but it is every citizen's business. To get a proper perspective, I think we need to place Kerala in the context of the status of palliative care in low and middle income countries, all the other low and middle income countries. When you have its data, the global data is available, which clearly shows that access to quality palliative care continues to be minimal outside North America, Europe, and Australia. And with the World Atlas, which mapped the development of palliative care in various countries, is pointed out that out of the 20 countries which has fairly well developed palliative care system, only just one is from low and middle income countries. That was Uganda. And then though the population living in low and middle income countries are much higher than population of the high income countries, only 30% of the existing palliative care services are in low and middle income countries. Various solutions have been suggested and a lot of advice have been given to these low and middle income countries as to how to develop and expand palliative care service. And when you look at it, you can see that most of the solutions are from high income countries. The rich countries tell the low and middle income countries how they should develop. And based on the experience of development of palliative care in high income countries and what is based on gold standard in high income countries, and discussions always are on how the recommendations based on this experience from the rich countries can somehow be rolled out in low middle income countries. And the problem with this approach is that it fails to see that the situation in most of the low middle income countries are quite different from the situation in high income countries. Both the healthcare situation, socio-economic status, various cultural issues. So you are looking at one different, an area with a different situation, and then you are suggesting that what is successful in a high income country should also be successful there without taking into consideration the viewpoint of the low and middle income countries. And most of the literature, voices from the low and middle income countries are very feeble globally, and most of the literature and most of the suggestions and most of the solutions come from the rich countries. Look at the model of home-based palliative care suggested, for example. Uh, the home-based palliative care available in high-income countries is based on availability of a professional team, which form the core of the home care team. And this is the model that has been suggested for poor countries also, resource poor countries also. And this is not practical, because you do not, you already, when you live in a low middle income country, you realize that, okay, you don't have adequate manpower. You don't have enough staff even to run the regular services. And the patients are in remote areas, and it's very difficult to travel to remote areas. So the model that is practical in a rich country may not be practical in a low middle income country. And then there are additional barriers. Additional barrier relates to poverty, additional barrier related to people being in lower in the social hierarchy, different priorities, caregivers not being able to work, loss of income. So this is also the situation when you belong to, if you belong to a lower socioeconomic group, whether in a high income country or low income country, then there are also other complicating issues. With this background in mind, let's also look at the current practice of palliative care. And there have been a lot of criticism raised about the current practice of palliative care. The main criticism has been that the original vision of holistic care is getting diluted. It's getting diluted and getting interpreted more and more in a restrictive way, focusing more and more on physical symptoms and psychological symptoms alone. And this keeps the communities away. This keeps the layperson away. This keeps the neighborhood away. This keeps the family member, the neighbors, the friends, people around the patient powerless, and make the patient and family dependent more and more on the professionals. And this sort of disempowering people and facing further demands on the services has been happening more and more in palliative care. In this background, Kerala's response need to be seen as an attempt to redefine how palliative care is understood. Kerala has been trying to redefine palliative care as the social experience with a medical component, not just as a medical issue. And this approach allows, that's as we have already seen, allows individuals, families, and communities to take an active role because they are also involved. It affects them also. Like when somebody is ill at home, somebody is ill in the community, somebody has a chronic illness, somebody is dying, it affects the community, it affects the neighborhood, it affects the family members. So if you when you redefine it as a social experience with a strong medical component, you allowing the layperson, you are allowing people who are affected to have a say, to contribute to the care, and feeling and help them to feel more confident about looking after the patient. And broadly, this is in line with the World Health Organization's Ottawa Charter in 1986, which basically has been looking at 5 areas, 5 pillars: building healthy public policy, creating supportive environments, strengthening community action, developing individual skills of people involved, and reorienting health services as an attempt to improve a population's health. And the question or the Kerala, the experiment in Kerala has been looking at the question as to how do we apply this to the health of those with incurable illness and the dying. I think we should not forget four basic things when you look at a patient with an incurable illness, when you look at a patient who is terminally ill or dying. The first thing is that terminal illness or incurable illness and dying, death, they all have social, psychological, and spiritual dimensions as also a medical dimension. And then also the second rule is the 95% rule. The 95% rule says that even in places where we have good institutions, most of the patients with advanced diseases, most of the patients with chronic diseases, most of the patients who are dying, they spend 95% of their time uh, at home or in the community. With family members, with friends, with neighbors, and the professional help or the contact with the professional is available only for 5% of the time. So 95% of the time is spent with the community. So this also we need to keep in mind. And also the pattern of the what we call the social epidemiology of dying, caregiving, and bereavement. It's not just physical symptoms. It's also a lot of other issues like panic, social isolation, anxiety, depression, loneliness, helplessness, and social rejection and stigma. So this is a complex. This is a complex issue of various issues and various things, various problems that the patient face, and you cannot just escape by saying that okay, addressing just physical symptoms and saying that we are covering it. No, that's not the solution. And we need to remember that palliative care need to be holistic. And when you look at the priorities, when you look at the key priorities, the basic issue is that how do we ensure that the society has a built-in system to look after these patients, rather than seeing these as isolated cases, because each one of us have to die one day, and most of us will have to be bedridden for a period before we die. So the society, these are not isolated incidents. These are not isolated incidents of one person dying. This is something that's happening in the society, and the society need to have a built-in system to look after this. And how do you prevent? How do you prevent suffering? How do you create a stable, supportive environment that prevents suffering, that reduces suffering? How do you reduce harm? How do you promote health? How do you promote even when you are with advanced diseases, even when you are terminally ill, your health is an issue. Sort of, how do you promote health at that stage? And how do you intervene early to prevent suffering? These are the basic issues that we should look at. And meeting these challenges will mean developing care in line with public health principles alongside the institutional priorities, and developing partnership with various sectors, social, cultural, for example, workplaces, schools, local government, because this is everybody's business. Health is everybody's business. Palliative care is everybody's business. Death and dying, looking after people who are dying. This is all these are everybody's business. And then we need to mainstream dying and seeing. Let's stop seeing death as a isolated incident. Death is not an isolated incident. This sort of seeing death as an isolated incident keep the dying person on the other side of the fence, and you are on this side as if you will not die. And this sort of ghettoing of mortality need to be avoided. And basically, this will mean creating compassionate communities inside and between institutions. And this practically means ensuring better participation of the community in the care of the patient, in care of the dying, in care of the bedridden, and less ignorance. Make sure that the community is not ignorant and the community is not responding ignorantly. Not just the community, the professionals also. Like we need to look at it comprehensively, the way it is, and then less ignorance and the less fear and helplessness in the community. They need to be taken in as partners, and also greater focus on social responsibility for palliative care, greater focus on social responsibility for health, because these are not just for the professionals. And again, less professionalization, less dependence on the professionals, and a greater access and continuity of care. These are the things that we need to ensure. The model that we follow in Kerala, the model that I've been suggesting, is what can be called a public health approach in palliative care. You need specialist care. You need specialists. You need people to train. We will need people to look after the complicated cases. You need people to give guidance. That's an area where highly skilled professionals are needed. And but they need to become only a small part of the caring community. Then most of the care should happen at the primary healthcare level. The primary healthcare system should know how to handle these issues. And then the whole community should know how to, the neighbors should know, the neighborhood should know, the family should know what their roles are, how they can contribute, how they can help in keeping the patient more comfortable. So this is the sort of model. This is basically called the public health approach in palliative care. Practically, the steps involve one orientation of the health and social welfare system because that's very important, and a lot of resistance can happen from there. I'll come to this point later. And then sensitization of the community, defining roles and responsibilities of different people in the community, different sectors in the community, and training for the community to capacity building. And maybe like if you have no experience in this area, then maybe starting a pilot project will be good, and then set up an audit cycle looking at feedback and then improving and expansion. This is the way we should be developing. And sensitization and training are the backbone of the whole project. Capacity building is the backbone, and continue capacity building. Never stop sensitization and training program in the community among professionals, and this need to be continued all the time. As a professional, when as a healthcare professional, when you talk about community empowerment, the most important thing that we need to realize is that you cannot develop a successful community program if you are not willing to give up power, because this will also mean you are losing power, you are sharing it with other people in the community, you're being more democratic, you are open to suggestions, you are open to discussions, you are open to criticism, because that is the key thing about the project. Community empowerment means you tend to lose power. We need to keep this in mind. Unlike most of the projects with blueprints, with the action plan, with the timeline that we are familiar with, community programs may sometimes be slow. It may take time, and usually what's observed is that up to a point it takes time, and when you reach a critical point, as has happened in Kerala, it takes off. And so you need to be patient, you need to be steady. Steady work at the grassroots level actually is the best tool for advocacy. Like rather than advocating with the government and lobbying with the senior people, policymakers, that may bring in results, but sometimes it may not be sustainable. But whenever you do grassroots level work, capacity building at the grassroots level, the results are sustainable. The results are long lasting. And then something that we observed in many places is that as the program becomes more popular, the government starts showing more and more interest. It's not the other way around. And something interesting that is observed is that the resistance and inertia, if you start a community program, the resistance and inertia is not from the community actually, it's from the institution, it's from the healthcare department, it's from the social welfare department, it's from ourselves, because we are trained in such a way that to change the mindset, we need to do some unlearning of our own priorities, the way we think. The major issue is the healthcare professional, and then institutions. We do not generally like people from the community interfering with our work. So that mindset need to be changed, and we need to be aware of this challenge, both from within ourselves and also from the institutions. Thank you very much, and I'll be happy to take questions or comments from you if we have time. And my email address is also given there. Please feel free to write to me if you have any reservations, if you have any questions, or if you have any comments to make. Thank you once again.